Good morning. I'm Neil Wenger. I'm from the UCLA Health System Ethics Center. I'm quite pleased to be here this morning, honored in fact. There's ample evidence that Americans inadequately prioritize advanced care planning. This is glaringly obvious because medical care is so plentiful in the U.S., and most incentives remain aligned for clinicians and facilities to do more. Even among those with inadequate access to treatment, it's available when they're the sickest and when it usually can benefit them the least. As a result, the data clearly show that U.S. spends more per capita than any other nation on health care, but the data are less clear, very much less clear, because no one is incentivized to look. But it appears that this nation leads every other nation in producing and propagating severely compromised health states, such as permanent coma, that virtually no one, if asked, would want, or very, very few would want, but no one asks. There's been considerable effort to increase advanced care planning and advanced directive use over the past 25 years that I'm aware of, 40 years that Judy is aware of. Yet most patients entering hospitals still have not completed an enduring advanced directive, and it appears that most with serious illness haven't discussed prognosis with their physicians. The data show that the majority of patients with incurable colon and lung cancer believe that their treatment is potentially curative. And it's sobering that those with more realistic prognostic understanding have less positive views of their oncologist communication. Dr. Tino, who's here with us today, has shown that the last decade has witnessed an increase in hospice use among decedents, but also more intensive treatment and more frequent transitions before death. There are many reasons for these trends, and one of them is measurement. The lack of it. Take, for instance, a patient with diabetes, hypertension, and ischemic cardiomyopathy who's admitted to the hospital with end-stage congestive heart failure for the third time in the past 4 months. Not an uncommon scenario. This guy is a potential heart transplant candidate. In a detailed chart evaluation of quality of care, we've looked at patients who are either transplant recipients or potential candidates and found that they're far less likely to engage in timely advanced care planning. This is despite all the extra attention and care coordination that these patients receive. During his hospitalization, this patient will be measured on medications received, lab tests performed, timeliness of cardiac procedures, and comprehensiveness of discharge planning. There will be no measurement at all about advanced care planning or match of treatments with goals. Some measures in this area do exist, not many, and none of them are currently part of any of the core measurement sets that are being applied. There has to be advancing of these measures, and priority has to be given to putting them into the EHR meaningful use regulations. The U.S. boasts the most widely available high-intensity medical care. At UCLA, I'm proud that if my patient admitted to the ICU could survive, he or she almost certainly will survive. But when medicine is overmastered by disease, high-technology medical care without advanced care planning all too often leads to suboptimal death. We prospectively quantitated the number of ICU patients that critical care physicians felt were receiving inappropriate medical treatment. Over a 3-month period, every critical care physician was asked every morning about each patient for which they were responsible. The physicians reported that 11% of their ICU patients were personally providing inappropriately aggressive treatment. 2/3 of those patients died during the hospitalization, 85% within 6 months, and the survivors remained in severely compromised health states, mainly attached to machines and long-term care facilities. There likely are many reasons for this, and we continue to investigate the factors involved. But the main one is a lack of a prospective advanced care planning with a continuity relationship so that the patient's informed preferences can be realistically matched to the treatments that are provided. Perhaps even more important than this physician-perceived inappropriate treatment that was being provided to these patients is that in many cases it affected other patients. These ICUs were often full, when a patient was being treated in a way that physicians felt was inappropriate. During that time, while these ICUs were full, many patients waited more than 4 hours in emergency departments to be admitted to those ICUs, and other patients waited many days, some never being able to transfer from other hospitals. But there's reason for optimism. There's evidence of increased focus on respecting choices at the end of life. There are a number of reasons for this, I think, including persistent efforts of policymakers and foundations. The findings from support are now, from Joanne Lynn's study, are now being realized. Comprehensive payment arrangements, such as for ACOs, will moderate incentives, and healthcare reform will restore trust among people who have not had access to medical care. Concurrent care programs, such as those available in the VA and Sutter and through a number of insurers that provide aggressive advanced care planning and palliative care simultaneous with disease-focused care for seriously ill patients, are demonstrating impressive outcomes with more appropriate transitions from curative to comfort-oriented care when prognosis shifts. Financial arrangements for these programs are needed. Programs that embed advanced care planning within advanced illness clinics also are demonstrating improvement. At UCLA, we're just initiating a program that's aimed at promoting innovative life-saving treatments for patients with failed organs at the same time as doing advanced care planning by embedding the palliative care nurse practitioner that's specially trained within our organ transplant clinics. These efforts require prioritizing advanced care planning as an essential aspect of medical care for clinicians, and institutions bear this responsibility. They do, but I'm missing my last page. There we go. And it needs to be recognized that it's bad medical care if fully informed preferences don't guide treatment decisions. It's not okay for a patient who is seeing a physician for progressive dementia to reach the point concerning artificial nutrition and hydration without having had a discussion. And this is something that can be measured. Similarly, it's not okay for a patient to receive escalation in treatment that doesn't afford clinical efficacy just because there was no planning for appropriate palliative care. So in summary, this requires an open public discussion about the goals of medicine and what outcomes are to be sought with healthcare resources. Such a conversation has been thwarted so far. These two brain death cases that Judy mentions show that we still trip over the language. Measurement of advanced care planning and end-of-life treatment can provide the tangible incentives to speed the redirection of these care patterns and also to inform this public conversation that we so much need to foster. Thanks.